One of the most common comorbidities in patients suffering from headaches is cervical pain, both before and after surgery. But is it important to know the type of surgery during rehabilitation? When it comes to managing patients after cervical spine surgery, particularly in cases of cervical radiculopathy, is of great clinical importance. Understanding the pathology and surgical approach is essential for optimal rehabilitation planning. Cervical radiculopathy results from compression of cervical nerve roots. This compression can stem from either hard compression, which happens due to degenerative changes such as osteophytes, which reduce the foraminal space and compress the nerves, or soft compression that involves disc herniation, where disc material protrudes into the spinal canal, compressive nerve roots. The clinical presentation varies and treatment depends on whether motor, sensory, or combined deficits are present. First category: painful radiculopathy without motor deficit. This is initially treated conservatively with physiotherapy and medication. Surgery is considered if symptoms persist. Second category: painful radiculopathy with motor deficit. It usually requires conservative treatment, but surgery is required if muscle weakness progresses. Third category: painless radiculopathy with motor deficit. This is often more serious and surgery is typically recommended to prevent permanent nerve damage. Physiotherapy can effectively manage pain, but its role in addressing motor deficits is less clear due to variability in treatment protocols. When painless muscle weakness is present, surgery tends to offer better outcomes. But what about common surgical techniques? One of them is anterior cervical discectomy and fusion, a well-established technique involving disc removal and fusion of adjacent vertebrae indicated for severe disc degeneration or instability. Also, cervical disc replacement, which is a newer alternative preserving segmental mobility, often preferred for younger patients with minimal degeneration. Posterior laminectomy is also a choice. It involves widening the intervertebrae foramen to decompress nerve roots, often preferred for lateral compression. When it comes to postoperative management, postoperative rehabilitation focuses on restoring function and preventing complications. Early mobilization, with surgeon approval, is now encouraged to enhance recovery. Rehabilitation includes strengthening deep cervical muscles for spinal stabilization, neurodynamic exercises to mobilize nerve tissue without aggravating pain, motor control training to prevent recurrence and optimize function. But we should also monitor for complications. Close postoperative monitoring is essential, particularly for dysphagia, worsening myelopathy, infections, or new radicular symptoms requiring prompt intervention. In summary, post-surgical rehabilitation requires a multidisciplinary approach, tailoring treatment to individual patient needs and ensuring close communication between patient, physiotherapist, and surgeon.